courses. Welcome, everyone. Thank you so much for joining. As I'm sure a lot of you know by now, my name is Shuaib. I am the course organizer for BitePACES, and we hold these free webinars basically throughout the year now. We've been doing them fairly regularly, and it's brilliant to see so many of you tuning in. And so many of you registering. But we also do have an in-person course, which is based in London. And we have a 1 day and a 4 day variation. And I think, like, without going into this too much, because I'm sure you guys want to crack on with the neurology teaching, we have some really nice cases, some great faculty, and we teach in small groups. So you're never in more than pairs, which I think is really nice because you actually get to know the patient and see their signs properly. And our courses are coming up in January and February. Please do sign up. For those of you attending the webinar, there's a discount code here, webinar 20, which will get you a little bit off the price. And here's some reviews. So 4.9 on Google, and we've got 30+ reviews now. And we're at www.bitepaces.com. Today, we're going to be covering some neurology. We've got an ophthalmology webinar coming up on the weekend as well. Sorry, this is the old schedule, I just realized. But basically, yeah, if you want to find out more about our free webinars, join our WhatsApp group. We post all of our free stuff on there. And if you want to join us in the course, just visit this QR code here on the left. But without further ado, I'm going to hand over to Paul, who's actually part of our faculty and teaches on our courses and is a fantastic tutor. He's a stroke consultant based in Dorset, and I know he does a lot of his own online virtual PACES teaching. So he's very experienced, and you're in very good hands. So Paul, without further ado, I'm going to hand over to you.
Okay, thank you so much, also Shuaib, for that lovely introduction. And I must say thank you so much for actually starting BitePACES, which has actually empowered a lot of doctors to pass their PACES. And so, as Shuaib has clearly introduced me, I'm a stroke consultant, and I've been doing a lot of PACES teaching in neurology also for a while. And so today I will just share a brief cases in neurology, and then also talk about some important tips, to pass your PACES. I'm just going to share my slides now. I just want to be sure if you could see my slide. Is it clear?
Perfect. Yeah, we can see those.
Oh, okay. Thank you so much. Okay. So I think we're just going to start with a little bit of this case. Then we dive into discussion about the top tips, to pass PACES. So imagine you have a consultation station with a 45-year-old woman with a history of tobacco use and headaches who presented to the emergency department with a 4-month history of episodic numbness and tingling of her right arm and face. And she reported a prodromal state of anxiety and irritability 24 to 48 hours, even before the symptom onset. And then you went on further to probing more about the history, and you notice that the sensory symptoms actually begin on her face and gradually progress down the arm and eventually to her fingers, then fully resolved within 2 hours without sequelae. Eyewitnesses, which included the family members, noted some slurred speech and with associated unilateral throbbing headache that improved with rest. On examination, you examine this woman, and all the examinations, cranial nerve down to the cognition, down to the motor limb, and motor and sensory examinations were all intact. And so the first question will be, what are the thoughts? And I guess it's a webinar. I don't know if people can interact, regarding the station. It would be very nice to see what are the thoughts of people. But I'm just bringing this also cases to highlight the importance of understanding where and what the lesion is in neurology. So even from the age of this woman, she's 45-year-old, and a lot of things starts to get in your mind. If you say young or patient or a middle-aged woman, in a neurology cases, even before you enter into the consultation case, you start thinking about differentials. When you say young person in neurology station, most of the time there are usually three group of differentials. Number one, either issues related to high risk behaviors. It could be drug use. It could be a lot of patients can come with stroke from also cocaine or amphetamine use, or it could be something related to an hereditary also also condition, like a lot of genetic problems. You see a patient with also Charcot-Marie-Tooth syndrome. Or the third group of differentials will be an autoimmune disease. So once you have a young also patient in neurology cases, start thinking about this group of cases that are very, very important. Another fourth group of things to consider are also functional cases. That's because we do know that in neurology, a lot of functional neurology disorder occur, in younger and middle-aged also people. So if you see a woman with a history of tobacco use and headaches, those things should start, running through your mind. But I think the key thing in the history were the what episodic numbness and tingling of a right arm and face. Obviously, this patient has come in with a unilateral limb problem and which resolved in the space of 2 hours. So the law of differential starts also coming in. The most important thing is you want to rule out the most sinister also cause of this, which could be a TIA. But a lot of features in this case that does not really suggest a TIA. Number one, there's been an history of 4 month history of episodic numbness. It's very rare also for you to have this, crescendo-like also TIA for 4 months without a patient having full-blown stroke. Or the fact that this thing is quite very stereotypic and episodic, makes you think of something else, as part of a cause of her symptoms. And she has a background issue of anxiety, which in your mind, we now start thinking of, is this something functional related? Those are very important. And that's why it's very important to ask these questions in a neurology consultation station. And the next thing in this case is the progression of the symptoms. Usually a TIA, symptoms are maximal at onset. So it means if somebody has a TIA, she would have a numbness on the face, in the arm and the legs at the same time. But when you see somebody having like a progressive involvement of different areas, like the face, the tingling in the face moves to the arm, then it's not really suggestive of a vascular thing. And you start thinking of something called migraine with horror. Those things should start, bringing up, in your mind. Those things are very important. And now there's now like a red herring, slot speech, which is usually meant to just distract you. You do know that migraine, especially people with also migraine with horror, they can present with, focal neurologic symptoms. And now the key thing that actually hits the nail on the head is actually the unilateral throbbing headache, which we do know that, it is classically associated with migraine with horror. So looking at these symptoms, and like I said, you did that examination was clearly normal. So bringing this constellation of findings together, a 45-year-old, although she had a history of tobacco, but the symptoms actually are recurrent, are stereotypic. A lot of those symptoms were actually more of like positive symptoms. Bringing this thing together, this is highly suggestive of migraine. But if you have a consultation station, it's very important for you to also exclude the most sinister thing, which is a TIA. And the reason is because she has a history of tobacco use, which we do know could be a risk factor for stroke. So before I dive into the next case, I just want to discuss about the issues about neurology pass rates in the UK at the moment. I've come with, unfortunately, some very sad news that neurology, in 2021, in the third diet, was the most commonly failed station, in the exam. And in the second diet of 2023 too, a neurology encounter had the lowest proportional mean score. And this does not just just include non-UK trainees, or even UK trainees had issues with passing neurology. And that's why my goal today is to just open you up to some very important tips in neurology. Now, this is the latest 2024, which is like, a chart which shows that neurology, if you look at that, the mean score of neurology is actually the lowest. A neurology score is usually over 20. So you shouldn't compare with actually communication, because the communication station is over 16. And yet, even neurology, the mean score was closer even to the communication station. So if you extrapolate at all the examination station, neurology is the most, is the one that most candidates have the lowest mark. And that's why today, my goal is just to demystify, and to also share some very important tips. As Shuaib has said, we do have also some very important also PACES courses, and I'll be there to support with any neurology stations and neurology teaching. But today is more of just like a tip in the iceberg. So what are the most important tips in neurology in PACES? Now, neurology is different from respiratory station or cardiology station, where you're just focus on the what. What is the cause of these symptoms? In neurology, the first question is where is this lesion? That is the first question. So you have to approach things very logical. So when you have a neurology examination or consultation, once you've examined the patient, the first thing in your mind is, where in the neural axis is this lesion? Is it in the cerebrum? Is it in the brainstem? Is it in the spinal cord? Is it in the peripheral nerves? Is it in the neuromuscular junction? Or is it in the muscular part? Those things are very important also, because you can't know the what in neurology without knowing the where. So that is very important. And today also, I would also talk about some pattern recognition, which is very important. And the third thing is, you need to approach neurology in a very logical way. Very logical. It's just like mathematics. You need to be very logical in your approach. And what I will always advise is what practice. Wherever you are, either in emergency departments, seeing new patient, clocking them in, just examine your neurology station properly as if you want to do PACES. So be very focused and practice. And practice. Those are very key things in neurology. So where is the lesion? I think that's the first question. So when you approach, an examination station, you want to ask, is this patient, is this lesion in the cerebrum? And when you see features of cerebral lesion, such as involvement of either the language area, involvement of the cognition, involvement of visual fields, or even if somebody has an MNEG, those are very, very strictly cortical problems. Or if you have an involvement of the cranial nerves, then you will know, it's likely that this lesion is above the spinal cord, and that gives you a very good tip. Now, when you see a cranial nerve lesion, just imagine you've got somebody with a facial paresis and you have weakness in the same side. That is highly suggestive of a cerebral problem rather than a brainstem problem. But if you see like a crossed hemiparesis, if you see features of cranial nerve problem ipsilaterally, and you see contralateral long tract signs such as weakness or sensation problems, then that is suggestive of a brainstem problem. So if you have ipsilateral cranial nerve and long tract signs, those are very, very specific for like a cerebral problem. But if you have crossed hemiparesis, then or crossed hemisensory lesion, then that could be suggestive of a brainstem problem. And brainstem problems, usually, if you have also multiple cranial nerve affected, those are very, important features of brainstem problem. If you've got symptoms, that is suggestive of posterior circulation stroke, like vomiting, nausea, nystagmus, diplopia, dysphagia, those are very specific for brainstem problems. And the next thing is also, sometimes you might have isolated cranial nerve problem, especially if you're dealing with a complication of a diabetes, or we could have a microvascular also third nerve palsy. So it's very important. So if you see a unilateral cranial nerve problem, signs, it might just be cranial nerve problem without involvement of the brainstem. But if you see multiple cranial nerve problem, it's likely an involvement in the brainstem there. Another thing is the spinal cord. A key thing about the spinal cord lesion is most of the time, it's usually bilateral lesions. So if you see somebody coming with also quadriparesis or paraparesis, those might be suggestive of a spinal cord problem. But the most important thing in a compressive spinal cord problem is a sensory level. You need to check. Once you have a bilateral limb weakness or limb problem and you have a sensory level, it is highly suggestive of a compressive myelopathy. Another thing to check is it nerve root problem or peripheral nerves? And like what I always say is if you find anything low in examination, low muscle power, low motor tone, low reflexes, everything low, you should think of what was peripheral nerves and nerve root problem. They're very key. They're very key. Now, if you now go on and you notice that there's absent, there's preserved sensation, and you have this low, then you should be thinking of predominantly motor nerve problem. And then in your mind, you'll be thinking of GBS, you'll be thinking of CIDP, you'll be thinking of multifocal motor neuropathy. Those are very key things. And the next thing is am I dealing with a neuromuscular problem? The key thing in neuromuscular problem is that most of the time, the reflexes, the tone is usually preserved. The reflexes, the tone is preserved. But most of the time, it will affect more of the proximal muscles. So if you see somebody with a normal tone and normal reflexes with involvement of the proximal muscles, and then involvement of a lot of the ocular cranial nerves, those are very suggestive of neuromuscular system. Now, the key thing in neuromuscular system, hitting the nail on the head is what we call fatigability. So when you ask, is it worse when I do an activity? Is the weakness worse, after a long time? Or does the weakness improves? So if there's variability in the weakness, that is very suggestive of a neuromuscular problem. So if there's a fatigability, is highly suggestive of myasthenia gravis. If the weakness improves with time, then you'll be thinking of Lambert-Eaton syndrome in this case. And then the last thing is muscular system. Muscular system is very, very, very similar to neuromuscular issues. But the key thing is that there's no variability in muscular problems. And muscular problems, most of the time, you have normal tone and normal reflexes in them. And significantly, you have more of a proximal myopathy, which is a very key thing in them. So the next question in neurology is what is a lesion? So once you've identified where this lesion is, then you're not be thinking, what can be the cause of this lesion in this anatomical area? And that is the next question. And usually an approach you can use is what we call the vitamin ABCD, which I'm going to show. It's very, very, very important, in thinking about etiology or causes of neurologic problems. Always think in your mind, could it be vascular, infectious, traumatic, autoimmune, metabolic? Just look through those things, and those things could be very vital, in thinking about the differentials. Now, when you have a patient in which you think, oh, this is likely a cerebral problem, or this patient has upper motor neuron facial paresis and has, this weakness in the same side, and you're thinking, oh, what are the causes in this elderly man? Obviously, based on the epidemiology, you think of what is it vascular first, stroke, and the second thing is, is a space occupying lesion? Is it demyelinating? Most of the time, those are the differential. Once you've localized a lesion to the cerebrum, it's easy for you to give differential diagnosis. Very easy. Vascular, space occupying lesion, demyelinating. If it's a younger person, a younger woman, then you put demyelinating first, and you can put the rest second or third. Those are very important. So etiology is very important, but you don't talk about the cause in neurology until you've identified where also the lesion is. And now I want to talk about also in determining what the lesion is. It's very important also to know, especially in consultation station, how 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 neurologic diseases present. So if you see a history, sudden onset, very few neurological things will give you a sudden onset problems. Most of the time it's vascular or seizure or rarely migraine, but migraine is usually hyperacute over time. Trauma also can give you the sudden onset, and also you could see metabolic and medications. So in vascular, ischemic stroke, intracerebral hemorrhage, most of the time will give a sudden onset lesion. Now, over acute and days, you can now look at also the vascular. Venous sinus thrombosis usually most of the time occurs over hours to days. You see somebody present with headache or, for over a few days, a bit confused, then seizures, then with a history of thrombotic history. That is very classical venous sinus thrombosis. And then you can go into subacute, chronic subdural hematoma, which is unlikely that you have in your PACES station. So seizure, also, like I said, also can give you very sudden. And other things can give you acute presentation, such as infections, usually over hours to days. And also, do not forget your inflammatory problems, usually occurs acutely too. So those are very important. Also, time course, very important. Is it sudden? Is it gradual? Is it progressive? Those things are very important. And when you when you are in a consultation station and you see a patient with a chronic problem, then there are very few differentials in neurology. Usually you'll be thinking of, is this, a tumor? Is this neurodegenerative problems? Is it vitamin B12 deficiency? Is it a genetic problem? Just imagine somebody with Charcot-Marie-Tooth syndrome. Those things, are very important to think in there. So the when is very important for you in knowing the cause of a lesion. And so once you've extrapolated where and what is a lesion, how do you now go to get your differentials? Usually I've explained the where times what. And the next thing is what, how do you think about the possible causes of his lesion? Because imagine the initial case I presented, 45-year-old with headache and positive unilateral symptoms. Based on our age, stroke is not that prevalent in that age. And so you'll be thinking, based on the frequency in that population, I would think the migraine might come first. And then the next thing is what? The likelihood of his symptoms being actually caused by a disease. This second subheading is actually, based on the Bayesian principles of diagnosis. Actually, they use it a lot in this artificial intelligence, in generating differential. So it's very important. So the frequency of a disease is very important. So a patient also can come in, very young with classical, very sudden onset symptoms of, like sudden onset weakness. But you think that looking at that young 25-year-old, no vascular risk factors. So although this patient had come with the classical symptoms, it's not that prevalent in that age group. And so you'll be thinking of other things. So it is actually a match between the frequency of a disease in a population multiplied by the likelihood of its symptoms also caused by the disease. Those are very important things to think of when you're thinking of differentials. There's something we call the Occam's razor, which just also talks about when you see a consultation station or you do a neurological examination, try to bring everything under one differential diagnosis. And it's called the Occam's principles, which is more like a principle of parsimony. But you do know that sometimes some patients can have multiple diseases, presented with multiple symptoms. So, and that is all about Occam's dictum, that sometimes you might not be able to fit everything into a box. Sometimes people can have more than one disease, and that's the Occam's dictum. And the three key approach to differentials is something I just want to also talk about. When you're making your differential, number one, put as number one the most likely based on your where, your what, your frequency, your likelihood. Put in the most likely cause as a first differential. And the second differential should be the second in your mind. What do you think could be the second most likely cause in this case? And the third differential you should always think about is what? What is the most sinister cause of this thing? That it's very important for me to mention, to rule out. Just like that woman who came in with a 45-year-old woman, known history of tobacco, with classic history of migraine with aura. If you are in a consultation case, you must mention TIA as a differential. You need to rule that out, especially with the history of tobacco use. Although it's not likely, but it's very important to rule out the most sinister cause, you know, in any consultation station or any examination station. And so, how do you approach investigations in neurology? After you know, you've done the history and physical examination. The key thing is that I usually, most of the time, they're usually basic things that is applicable everywhere. Bedside test would always, ABG, spirometry, if you're thinking of GBS or if you're thinking of myasthenia gravis, BM, if you're thinking of diabetic neuropathy, urine deep, ECG sometimes could be relevant, especially myotonic dystrophy, in some of these also genetic problems. Then blood routine or specialized blood, lumbar puncture, most of the time, if you're thinking with a, thinking of an inflammatory problem, thinking of multiple sclerosis, thinking of infectious problem, GBS, lumbar puncture, imaging, you would always need to talk about imaging, CT and MRI, PET, neurophysiology, sometimes EEG, if you're thinking of seizures, nerve conduction study, if you're thinking of any neuromuscular, any peripheral nerve or any muscular problem, you must mention. So those things has to be there, in your catalog of investigations. And if you think this thing is genetic, then you might think about also genetic, also testing. And so, yeah, finally, before we go, unfortunately, I'm not sure if this is going to be interactive. I wanted somebody to actually also talk through this case, but looks as if I'm not sure if Schwab, if
Hey, Paul.
yeah, is it possible for it to be interactive or it's not
Yeah, you,
possible?
you, do you want one of the people here to do the case with you?
Exactly, yeah. And
Okay, cool. Yes, if there's anyone who's willing, please put your hand up. We can pull you over and you can run through the case with Paul. It's no judgment. We've had some
exactly.
people do this before, and it's really for your own benefit. So don't feel shy.
Yeah.
But if any willing participants, please do raise your hands. We'll give you like kind of 30 seconds.
Oh, fantastic. We've got
Oh, yeah.
it's Finton.
Okay.
Okay,
Yeah.
okay, great. So I just wanted to read this case also to me, and I'm happy to scroll that. Then I'll just ask you some questions. Is that okay?
One second. Where I can't find, is it Fintown?
Yeah, yeah. She actually
Okay.
raised a hand now.
Yeah.
Yeah.
So if I, how are we going to do this? Promote to panelist, maybe.
Oh, yes, yeah.
Okay. So Fintown, I think you need to unmute yourself.
Thank
Oh,
you.
okay.
Thanks very
Great.
much.
Thank you so much for volunteering. I really appreciate it. So I think what we're gonna do is you're just gonna read this case. Just then I'm gonna ask you, where you think the lesion is, what is a lesion, differential diagnosis, investigations, and management, and that's all. So just feel free. I like that you have a big smile. You're very positive. That's great. Okay, let's keep it there. Okay.
Thanks very much.
Yeah, you're welcome.
So do I ask some questions like take a
No, no,
history?
no, no, no. Just read it out
Good.
to people. And
So Leanne, 25-year-old bartender, comes to the hospital with difficulty walking. She is normally fit and well. Over the past week, she has been experiencing back pain, and over the past few days has been losing the strength in her arms and legs. Yesterday, she was unable to reach up to the highest shelves to bring down the pint glasses, and today she is having difficulty walking even a few steps.
Yeah.
She has not had any double vision, but on one or two occasions, when she was swallowing liquids, she complained that they would go up her nose and she would choke. She was not breathless, bowel and bladder functions intact. She has had 2 weeks ago a 3-day bout of profuse diarrhea. On examination, she had slight difficulty swallowing water, but the voice was normal, the cough was good, the cranial nerves were otherwise normal, no wasting or fasciculations, tone was reduced, power was reduced symmetrically to 3 out of 5 in proximal and 4 out of 5 in distal groups in the legs and the arms. All of the reflexes were absent and the plantars down going bilaterally. Sensation was altered in all modalities in the legs to knee level and in the arms to mid forearm level. There was no sensory level slash cerebellar and cerebellar intact.
Okay, very interesting. Thank you so much, Vincent, for that. So the first question is, now let's go to the examination first. Because where is the
Okay.
lesion? I think that's the first question. Where do you think is a lesion? The first question is, where do you think is a lesion? Is it in the cerebrum? Is it in the brainstem? Is it in the spinal cord? Is it in the peripheral nerves? Is it in the neuromuscular system? Is it in the muscular system? From the examination finder, where do you think?
I think it's peripheral nerves
Fantastic. And why do you think so?
because of the absent reflexes, along with the reduced power and the downgoing plantars, and then the fact that there's no sign of cranial nerve defect or any cerebellar signs.
Fantastic, fantastic. I think that's very, very brilliant, very, very brilliant. And so we've seen that even in this case, everything was what's low. And I said, when you see everything low, low tone, low power, low reflexes, it can't be anything other than the peripheral nerves. That is it. So, and the next question will now be, what sort of peripheral nerves is it? Is it, a mononeuropathy? Is it a polyneuropathy? Is it predominantly motor neuropathy? Is it mononeuritis multiplex? Those are now the next questions. So now you've rightly located this thing in the peripheral nerves. And the next question is, what sort of peripheral nerve? Is it mononeuropathy? Is it polyneuropathy? Is it mononeuritis multiplex? Based
I think it's a polyneuropathy, and it looks
polyneuropathy.
like it's length dependent.
Length dependent. Why do you think it's length dependent?
I think because the power is more reduced. Um, I might take that back potentially.
Yeah, yeah, yeah.
Yeah, I'll
It's
stick with
non-length
polyneuropathy.
dependent, right?
Yeah.
Yeah, because it's more of like a proximal motor, weakness, much more than distal. Obviously, if the distal weakness was more, then we'll say, oh, it's length dependent. And most of the time, length dependent polyneuropathy has multiple metabolic causes. But now, this is a polyneuropathy, but it's non-length dependent. Now, going back now we know where the lesion is. And the next question is what? What is a lesion? And, I mentioned the vitamin A, B, C, D, E also to you, right? So
Mhm.
based on the history now, 25-year-old woman. And so the question, like I said, when somebody young comes in, is that what things related to high risk problems? It could be drugs, it could be sexually transmitted infection, it could be like just eating anyhow, anything related to travel, anything. Number two is it something inflammatory most of the time when you see young people, or is it genetic? In those three group of cases, The fact that this thing just is an acute illness, so it knocks off a genetic cause, right? And you're faced with, is it something related to more the high risk or inflammatory? And now looking at the history now, what do you think are the possible causes of this non-length dependent polyneuropathy?
I thought maybe Guillain-Barré syndrome when she had the history of recent diarrhea. That was
Guillain-Barré, fantastic. Yeah, I can see some people are putting some very interesting things. Miller-Fisher syndrome, GBS, great, inflammatory, good. Okay, so the question is, why is she having back pain?
I'm not sure if it could be a red herring, if that's
Yeah.
the right expression.
Okay. Now, just to also tell you that in AIDP, in GPS, also because sometimes it affects the roots of the nerves, it can cause all this back pain, more because of a radicular involvement. So back pain sometimes does not exclude GBS. It could sometimes be there. Then you can see that clearly from this one. Yesterday, she was unable to reach up. So it means it's a proximal, muscle involvement, and which we see in GBS, in AIDP, most of the time, it's non-length dependent, which means it's different from the other causes of polyneuropathy that most of the time will affect the distal part. So it affects more. The weakness is sometimes worse, more on the proximal aspect of that.
Thanks very much.
Yeah, and then we move here to no double vision, which is reassuring, which actually knocks off a lot of usually in Miller-Fisher syndrome, you see the triad. And what is the triad of Miller-Fisher syndrome?
Is it ophthalmoplegia?
Good.
Um, uh, descending,
Yeah.
weakness and
Hemiplegia,
sensory signs.
ataxia, fantastic, and areflexia. So in this one, she did not have any double vision. So this is unlikely to be the Miller-Fisher variant of that. So now, obviously, it's affecting what? Her swallowing. So I think these things are very important also to note. So this thing is rapidly evolving that. Unfortunately, the good thing is that she's not breathless at the moment. And now, this now helps us a lot. And that's why when you are faced with those consultation stations, very important to ask about what? History of what? History of, the risk factors, diarrhea, flu, which sometimes can provoke, GBS. And then, so in the examination, we have the cranial nerves were normal, which is reassuring, no wasting of fasciculations, which excludes most of the time the MND, motor neuron disease, and so on. So based on where it is, we are very sure this is a non-length dependent polyneuropathy. Based on the history, based on the demographic, based on the where, the what and when, we do believe that this is likely, an ascending inflammatory demyelinating polyneuropathy. And so the next question is, what will now be your differentials? You see these patients in PACES station, what will be your key differentials there?
I suppose if there was some other condition that could affect the nerves, say B12 or folate deficiency, maybe, if she had very low levels.
Okay,
Or
good. Yeah, fantastic. Always think about other causes of polyneuropathy in this case. Good. And what other differentials will you be thinking of?
maybe she could have some other form, like I'm not sure, of like mononeuritis multiplex.
Exactly, which is also a possible thing here.
Or
Somebody saying infection like also botulism. Yes, it is. Yeah, it is something to consider. But most of the time, that botulism shouldn't affect, it shouldn't cause back pain. It shouldn't cause, it shouldn't cause what again? Most of the time, it wouldn't really cause the sensory problem. So, botulism is a differential because it's one of the also causes of descending. Apart from Miller-Fisher syndrome, also botulism is very important in this case. Multifocal motor neuropathy, fantastic in this case.
maybe
Good. So I think we've seen a lot of, differential. People here are very hot in neurology. So now let's now talk about how we do investigate Vincent. this patient and manage?
So I think that I would start off by doing a set of bloods, checking inflammatory markers, ESR, CRP, white cell count, and then since I think it's more likely to be a peripheral nerve problem, I'd be thinking that she may need to go down the route of getting maybe nerve conduction studies or
Fantastic.
an EMG. And
Great.
I would wonder maybe she might need lumbar puncture if we're thinking infection as well.
Fantastic. And before you do the lumbar puncture, would you want to do anything else?
I think a CT brain or maybe just to exclude any sign of raised pressure.
Great. I would always think of doing an MRI brain and spine in this case, just to exclude always mimics,
Mhm.
and just good. And always before you do a lumbar puncture too is always very safe, even to do that. Fantastic. And the nerve conduction study, fantastic. And then what will you be looking for in the lumbar puncture, classically for GBS?
So I would wonder to see a raised white cell count.
Well,
Um,
it's the opposite, right?
right.
A raised protein with normal white blood cell count. It's called a cyto protein dissociation. So the lumbar puncture will show elevated protein with like almost normal white blood cell count. So it's like a dissociation. So yeah,
Mhm.
between the protein and the white blood cell count. But fantastic, Finton, you've been very excellent. And so, how would you manage this patient? How will you treat this patient?
So starting off doing an ABCD approach to make sure any acute problems have been managed and did she stable, and then moving from there you would be um discussing with neurology and making sure there's no respiratory compromise, getting swallow assessment, and then MDT approach as well in terms of
Fantastic.
long-term management.
And what would you want to do very fast in this patient? Swallowing
Yes.
involvement?
Apologies, sorry.
Yeah.
Swallow assessment, maybe?
Yeah, in case there's no neurology, just overnight, no neurology to talk to, and you feel very highly strong that is like, it's likely, a GBS. What medication will you want to give this patient? Yeah, I've seen that people are putting plasma pheresis. Fantastic. Yeah, IVIG, those things are very thing you want to do. People usually don't respond to steroid. ITU, very important, is affecting the swallowing. So you should think a lot about that, about making sure that the ITUC, you want to do your vital capacity FVC, very important, serial FVC monitoring and so on. And long term is always once they recover from the acute, phase, usually you need MDT, physiotherapy, speech and language therapy, obviously with the swallowing, and occupational therapists might be very informed. Fantastic. Well done, Finton. You're brilliant. Thank you so much for offering. So
Thanks.
yeah, I think that is a hand, and I think just to summarize is that, as I've said, the key thing in neurology is what is where and what of a lesion. Very important. And also in making your differentials, you should look at the frequency of a disease and the likelihood of the symptoms being caused by the disease. You should try to always think about, the three differentials in your head. The most likely, the second most likely, and the third differential is the most sinister. And as I've said, just be very what? Be very logical in your approach. Neurology is easy. I've a lot of students, a lot of doctors that have actually taught, a lot of them get full marks in the neurology station. A lot of them, I've had many messages, people just saying it looks daunting, but it's simple. Once you get the approach, where is this lesion? You understand pattern recognition, and then you now go to look at what could be the cause of a lesion. And if you practice, do it several times, you will, get a full mark in your neurology station. So I hand over to Schwab. I think that's the end of my talk today. I don't know if there are any questions.
Thanks a lot, Paul. I think that's brilliant. And I think you're absolutely right. Well, certainly, I'm sure neurology is very difficult, but certainly for the exam, I think it can be simplified to something which isn't that difficult. And I think we sometimes overcomplicate it. So that's very true. So I'll hand over to you guys now if there's any questions, if at all. I'll pose them to Paul. Just have a You can post your questions in the chat rather than the Q&A if that's okay. Let's have a look. A lot of people answering questions, which is nice, but I can't see no one has any burning questions, it looks like. Okay, cool. Should we wrap up there then? That's good timing. Well done, Paul. Thanks so much for that. That was really useful, and particularly the case-based approach, I think was really nice. I'm sure that everyone really found that useful. Oh, we just had one question come in, if that's okay. Someone's asking about explaining where the lesion is. There was a slide.
Yeah, is it the lesion slide? Yeah, is it this one?
I think
Yeah, so
I assume it's that one.
oh yeah, so I mean, it's just locating where the lesion is. I think it's very important. I can't go through the pattern recognition for each of them also today. But I do think, I should be in the next bite paces. You might see a lot of cases and you're able to see how our pattern recognition. So there are a lot of things about, if you think this patient has a cortical problem, I mean, if you see features of cranial nerve problem and you've got a ipsilateral, it means the same side, you've got a long tract problem, like a limb weakness or a sensory problem in the same side with the cranial nerve, that is likely, a cerebral problem. If you see like a cross lesion where the cranial nerve lesion is on a unilateral side and a long tract signs is in the opposite side, that's likely a brainstem, also pathology. If you see multiple cranial nerve involvement, it also means a brainstem problem. Sometimes you could have single cranial nerve problem without even involving the brainstem. For example, the diabetic microvascular, also third nerve palsy. And spinal cord problem, usually when you say bilateral problem, it could be quadriparesis and paraparesis, and especially if you now say sensory level, that's very, very specific for spinal cord problem. But you know that it's not all spinal cord problem that will give you sensory level. It's only when it's compressive. Sometimes it could have vitamin B12 deficiency, which might not give you a sensory level. But the key thing in spinal cord problem is upper motor neuron signs, and you have a bilateral, or quadriparesis. And when you have a nerve root or peripheral nerve problem, like just the explanation I've said, if you have everything low tone, low reflexes, low muscle power, it cannot be any other thing but a peripheral nerve problem. The key, low, everything is low. And neuromuscular problem is if you see things, are normal, apart from power, normal tone and normal reflexes, and you see, low power, but most importantly is there's variability in the symptoms. When you ask the questions, okay, does a weakness get worse over time or does it improve? Once you have symptoms, features of that with a normal to normal reflexes and reduced power, especially in the proximal aspect, then that is suggestive of neuromuscular problem. Neuromuscular and muscular problems are similar. The only difference is what muscular problems are not variable, are usually very, very fixed. There's no variability in the weakness, and most of the time, as we know, it's usually proximal. For somebody having problem, actually getting up something, or somebody having problem standing up from a sitting position or climbing the stairs, those proximal, problems are typically in muscular system. So there are a lot of other things, that but I think as you come to bite paces and so on, you'll get more of the tips, for that. Okay.
Yeah, I think that's key. It's just I know the basics, how to localize, and then obviously certain things come up time and time again in PACES, and just know those things and see patients on the wards and courses, and you'll slowly put it together. We'll take one last question, which is what part of focused neurological examination would you expect to be done within 15 minutes for a GBS patient? So they mean like in a clinical
15
consultation.
minutes is quite long. You've got 6 minutes.
That's for the neuro. I think maybe they mean
Examination.
for the clinical consultation, perhaps. I
Yeah, even the
imagine.
clinical consultation,
You're
if
right.
you
You have
have
to keep
some,
it short.
yeah, in the clinical consultation, yeah. I mean, I think the key thing is to just obviously just very brief cranial nerve examination, more looking at obviously the ocular movements, the facial movements. You don't need to do 8 I mean, you obviously need to check also 9, 10, 11, 12. Those are very important. Then a very quick, you know, motor power tone reflexes examination of the upper and lower limbs. Very quick ones, not in depth, and that is it. It's very rare that you would actually have this thing in consultation station, but it could happen in consultation station. But the key thing is that from a history, you already think, okay, this might be GBS. So you just and for consultation station, it's all about focused neurological examination. You do the most important thing, focused, and then yeah, you'll be fine.
Nice. Let's leave it there, Paul. Thanks so much. That was hugely helpful. And I'll let you go to enjoy the rest of your evening.
Thank you so much.
All right. Take care, everyone.